to show them as they're having the test to see if they're pushing correctly, because most of them are not. They're straining, they're not pushing correctly, and I try and teach them that to use at home. That comes back to with the holding patients who have a lot of PI pain, hard stools. We find Botox works well with these patients, not all these patients. And of course, that's another presentation that we can talk about, but it's something that we've used very well. Irrigation is very well used in the UK. Neuromodulation, early days. I've used all these techniques, but I've only used the tests and the sacral nerve stimulation in pediatrics. In very selected cases, obviously. Those with slow transit constipation tend to do very well with the test machine, and the SNS is usually the last resort and in very selective cases. And of course, as those patients, again, who have slow transit and are not doing really well, who may benefit from the ACE stoma, whereby obviously we know we can put the medication via the appendix or the distal side of the rectum. And unfortunately, there are some cases where we have to give them a stoma because there's no other way we can deal with them. So I think the same, I'm trying to find patterns, I'm trying to find phenotypes, and I think it will take me a couple of years to get there. But what I can see so far, the abnormal bowel scores correlate with quality of life and risk of distress. They're very useful. Organic constipation may be predictive of poor physiological outcomes. So I try to say to parents that when we will most likely find abnormalities when we do physiology. Younger patients may have the tendency to withhold. I think we know that. Abnormal transit study usually leads to abnormal physiology, bowel scores, psychology. So it's a good guidance. I don't think normal physiology will rule out other possible triggers. So I don't think it should be used only by itself. I think bowel scores, as I mentioned before, is a good predictor tool for quality of life and risk of distress. And I think that we all know that fecal incontinence is not only there, but it's a persisting problem and it's having a huge impact. And I think the main thing that I learned working the last couple of years with my service is that a lot of these things I've talked about today influence clinical management. Most of them do require comprehensive assessment. So we try to do like a one-stop shop, ideally to do everything in one day, if possible. And I think that anorectal manometry does have a purpose, but in combination with other complementary tests. So just looking at the one test result in isolation without the other test results, without the multiple disciplinary team, it's a very limited value, I think. So in conclusion, I just want to say that we all know that chronic constipation of any nature is multifactorial and complex. There's no sole diagnostic tool that will unravel the pathophysiology and the symptoms of these patients. Again, the implementation of any treatment targeted on one area of dysfunction may fail, so that you need to apply a multimodal approach to treatment modalities in order to reach the continence level. And I think we don't have any clear phenotypes yet. It's evolving, but we still don't know enough. There are plenty of other tests that we can do still that are more advanced, but I still think we need to go back to the basics. Obviously, I have a lot of ideas that I want to explore in my service. I want to look at the functional and structural in more detail. I want to explore the deification dynamics, compliance and behavior as an area that I think is neglected. And obviously, I want to perform normative data for anorectal manometry, bowel scores, and bowel function as well. So I hope that my presentation hasn't been too simple, but I hope it kind of gives you a bit of guidance if anyone out there to use this scientific evidence to guide management, that clear indications are needed for intervention, not to do something just for the sake of doing it. Appreciate how multifactorial this condition is. Give it time, there's no quick fix. I say this to my patients all the time, that it does take time, and a lot of it is behavioral and psychological, and that obviously we can't fix overnight. This is my team. So Mr. Stuart Cleve, who I work quite closely with, he's the lead, I'm the director. There's my gastro team. Some of these people have left, but Marco Casparetto and Lavenia who are currently with us, who I work quite closely with. Our nurse specialists who do a lot of the irrigation, the stomas and other areas of continence. My play specialist, Tara, who's actually doing a PhD with me at the moment. on children with trauma and constipation, and our clinical psychologist, Kate. As I said to you before, we have a training and study day every year, which I organise. This year, thankfully, I did not organise one, and ideally because it would have been cancelled. If you're interested, please let me know, and I'll let you know when we do our next one for 2021. Thank you very much.
Thank you, Eleni, again for having accepted our invitation. We really enjoyed your presentation. Look, there are two people that would like to ask you something.
Okay.
First of all, Dr. Domenico Della Casa, if he wants, he can ask directly to Eleni. I don't know if he's still online.
Oh, okay, probably did you hear me?
Yes, we can hear you well. Please go.
First of all, thanks to Eleni for your presentation. Second, sorry for my horrible English. During your presentation, you said only there's no one normal value at squeeze maneuver, but on the others maneuver, for example, normal resting pressure or other maneuver, for example, balloon and so on, have you different normal value due to different age of your child or not?
So there's definitely normal values out there. You know, there's a publication that was has shown normal values in 3D manometry. The main issue is that when you compare your results with your setup and compare it to someone else's setup, it's not very scientific. So I tend to just use normal values that I know is of course it's not perfect, but it's the same setup as my adult team. So same catheter size, same setup, same program, same analysis. And it's something that I have to do. I'm currently going through ethics to get normal values. And I know there are people out there who have done normal values around the world. It's just, we can't necessarily use them. And if we do use them, we have to explain that we are using them with some discrepancy there.
Okay, thanks. And also, if I can, second question.
Yes, go ahead, please.
Have you an experience with 3D anorectal manometry and also with little child? Because I well know that the diameter of this probe is, let me say, large, wide.
Mm-hmm. Yeah, so I have to be honest, I haven't. So there are a few things I want to explore. I just felt like I had to go back to the basics. I had to start off with a very simple, you know, high resolution and ultrasound to begin with, because as you said, the probe is something that is very difficult for them to tolerate. I mean, when I do physiology, it's okay, but when I do ultrasound, I make sure the child does not see the probe because it'd be very scary for them. But I would like to explore 3D manometry later on when I'm a bit more established, because I think at this point it's just there hasn't been much funding and room for it. And obviously we've just got funding for colonic manometry as well, which also I like to explore, and I think it'd be very useful in our patients with slow transit constipation and those who've had an ACE, for example. So to answer your question, I haven't used it, but it's something that I want to eventually. But it's very difficult in these patients. They don't like things there in their bottom, and it's just, you have to be very careful, because obviously as much as we as clinicians we're trying to get the result, it's going to cause them trauma and they're not going to comply to things in the future.
Thank you.
Thank you, Eleni. Also, Dr. Tamara Caldaro from Rome would like to ask you something. Please, Tamara, can you ask Eleni?
Yes, no, Renato is speaking.
Hello, Renato. Please go ahead with your question.
Eleni already replied to my question about the colonic manometry. She has no experience right, Eleni?
With colloid manometry, my experience is very much, I've obviously performed it and so on, but it's not something I have yet set up in my service. So I've just got funding for it. So I'm planning to do some research on that in the very near future. You have to understand, I think one of the biggest flaws we've had is the lack of funding to set up everything. You know, you can imagine, I don't know if this is a worldwide issue, but getting funding for anything to do with these kind of things is very difficult.
Okay, thank you. Yeah, I want just to about the 3D catheter. The main problem is that normal values are different because of the Laplace law. If the catheter is larger, you may have an overestimation of the resting pressure, and so that's.
Yeah, this is why it's very difficult, because, you know, obviously I encourage people to do to look at normal values or not healthy children in their service when they're comparing to their abnormal. However, you know, it's taken me 6 months just to get ethics to appreciate this, and now I'm in my second stage where I'm submitting my ethics form to get this approved. And what I've done to do this, to get the numbers I need, is to ask the children and the the patients and their parents if their siblings or their cousins would volunteer. And the thing is, most of them said yes. 40% said yes, because obviously they want to help. It'd be very hard for me to advertise to get healthy volunteers from from anywhere. So so that's taken 6 months just to gather that information and to get that support. But yeah, it's very hard. I agree. My research has been very limited with the lack of scientific normal values I have. But it's something we can't rush, because it's going to take time to get to that stage, I think. But we shouldn't discourage us to not use anorexia manometry, of course.
If you want, we can help you having more patient.
Oh, okay. I'll be happy to.
Thank you, Eleni. Also, Dr. Francesco Italiano from Rimini has a question for you. Please, Francesco, let us. Okay, we can see you and we can hear you well. Go ahead with your question.
Thank you, Elena, for your interesting presentation. I want to ask you if you are some experience in neuromodulation, in constipation, functional constipation. What's your technique that you prefer, do you use, and if the results are stable from manometric point of view? I mean, if you test the result with manometric before and after the use of neuromodulation. Thank you.
Yeah, very good question. So the neuromodulation that I've only used here at the Royal London in children is the transcutaneous electrical stimulation, whereby the child obviously has pads on their abdomen and back. We find, so it's very hard to know when to use this management, but we feel when a child has slow transit constipation and there is the lack of complete sensation there, they may benefit from this. I've only done a small amount of patients because some patients are not compliant, and some patients I haven't asked them to come back for manometry at this stage. But I found those who have got slow transit and those who also have hypermobility or Ehlers-Danlos, they seem to do really well with the test machine. It's an area that I need to explore. I think it's taken so long, 4 years, just to get the basic setup done. The sacral nerve stimulation, I've only done a few back in my days. And it has been very useful in some patients with anorectal malformation, for example. But I haven't done a pre and post study. The PTNS is something that I know I have done in adults, and we have found manometric differences and improvements. But I haven't done PTNS in children. It's just taken, I think, because we have such limited information out there. I just want to